good morning, or good evening, depending on where you are joining us from. My name is Sanchita Saxena, and I'm the director of the Subir and Malini Chowdhury Center for Bangladesh Studies and the executive director of the Institute for South Asia Studies, where the center is housed. The Institute for South Asia Studies at UC Berkeley has always had a deep commitment to Bangladesh, but this has been even more pronounced with the establishment of the Chowdhury Center in 2013. Through partnerships with leading institutions in Bangladesh, a vibrant lecture and conference series, and support of innovative research by graduate students, the Chowdhury Center has galvanized debate on many key issues around the economic, societal, political, and environmental transformations facing the country. These are unprecedented times, but we are committed now more than ever to bringing cutting-edge scholarship about Bangladesh by leading experts in the field. Today, I'm very pleased to welcome you all to our program, Strengthening Maternal and Newborn Care in Bangladesh, a presentation on the USAID-funded Mamoni Maternal Newborn Care Strengthening Project. Today's event will start with two presentations, and then we will have responses by two of our discussants, and then a discussion amongst all the panelists. Finally, we will end with a question and answer session. So please continue throughout the presentation to put your questions in the Q&A box. I would like to welcome our first presenter to the virtual stage. Dr. Meena is a public health expert with over 20 years of global health and development experience. Currently, she is leading USAID's Mamoni Maternal and Newborn Care Strengthening Project and emergency response to COVID-19 pandemic as the chief of party. Her sectorial experience includes maternal, newborn child health and health system strengthening in Bangladesh and Canada. She has a keen interest in health quality improvement and quality of care. Prior to joining Save the Children, Dr. Meena worked for the Middlesex London Health Unit in Canada and USAID Bangladesh. Dr. Meena, welcome to the virtual stage.
Hello, good morning and good evening, colleagues, based on wherever you are. My sincere gratitude to Subir and Malini Chowdhury Center for Bangladesh Studies at University of California for offering their platform to share USAID's Mamoni Maternal and Newborn Care Strengthening Project's experience in working with Bangladesh public health system in improving maternal and newborn health status. At the beginning, I will share a quick overview of the country and how it is moving forward in achieving the Sustainable Development Goal 3. Since many of my colleagues who joined this webinar are not familiar with the Bangladesh health system, which is imperative to understand how the project is working, I will talk about the system and the structure. Then I will explain how USAID's Mamoni MNCSP works under the leadership of the Ministry of Health and Family Welfare. And lastly, the significant results that the project achieved and experience gained in the last 4 years in contributing to the reduction of maternal and newborn mortality. Bangladesh is located in South Asia. Bangladesh shares land borders with India to the west, north, and east, and Myanmar to the southeast. To the south, it has a coastline along the Bay of Bengal. It is the 8th most populous country in the world. It has the size of Iowa state of United States, but the total population is 166 million. The country has 64 administrative units called districts. Mamoni project works in 17 of them, covering 35 million people. Bangladesh's Sustainable Development Goal commitments are to reduce the maternal mortality ratio to 70 per 100,000 live births, reduce neonatal mortality to 12 per 1,000 live births, and increase the skilled birth attendance delivery rate to 80%. There are 6,076 maternal deaths each year. Most of these deaths could be averted by skilled care, before, during, and after childbirth. There was a rapid decline of maternal mortality between 2001 and 2010. Within this time frame, the maternal mortality ratio came down to 194 from 322 per 100,000 live births. According to the Bangladesh Maternal Mortality Health and Healthcare Survey in 2016, Bangladesh's MMR is 196. The country witnessed a stall in the mortality ratio between 2010 and 2016. The last maternal mortality survey was conducted in 2016. According to the SDG tracker that uses UN estimates, in 2019, the mortality ratio was 165. Based on the trend, we believe to achieve the SDG target timely. The World Health Organization conducted a multi-country survey and identified the stages of obstetric transition based on maternal mortality ratio and categorized countries in groups. Bangladesh falls under stage 3 group, which means in overall consideration, the quality of care, skilled childbirth care, and adequate management of complications are useful and essential for the reduction in maternal mortality. And USAID's Mamuni MNCSP has been working to address all those areas of recommendation. This slide shows a comparison of causes of maternal deaths between globe and Bangladesh. Causes are quite similar to what we see in other parts of the world. Hemorrhage and eclampsia and preeclampsia are the most common causes of maternal deaths, followed by indirect causes, abortions, and obstructed or prolonged labor. 1/5 of the maternal deaths are due to indirect causes such as cerebrovascular and cardiovascular complications, liver diseases, etc. In Bangladesh, neonatal deaths constitute 67% of overall under 5 deaths. Although the country achieved the MDG target for under 5 mortality rate, from 1994 to 2014, there has been a sharp decline in under 5 mortality rate, from 134 to 46 per 1,000 live births. However, within the same time frame, neonatal mortality declined only from 52 to 28 per 1,000 live births. This much slower reduction of neonatal mortality led to a rise in the proportion of neonatal deaths in the overall under 5 deaths, from 40% in 1993 to 60% in 2014. Neonates who die suffer from conditions or diseases that are mostly due to a lack of quality of care during birth and post-birth management. Skilled and quality care is essential to avert this scenario. Bangladesh has to further reduce under 5 mortality by 44%, including newborn deaths by 60% to achieve the Sustainable Development Goal. 3 out of 4 babies are dying due to 3 main causes, and they are premature or low birth weight, interpartum complications, and sepsis, which is similar to the global causes. Here are some statistics on coverage indicators to understand the service utilization pattern. Over the years, all services utilization increased substantially. Likewise, the antenatal care utilization rate increased, and now 47% of women are receiving antenatal care for service from medically trained providers. Almost half of Bangladeshi women still delivers at home. Among 49% of facility deliveries, 32% takes place in private facilities and 14% in public facilities. Current postnatal care utilization rate is 52%. As women prefer to deliver at home and most of them are assisted by untrained providers, essential newborn care among home births are as low as 7%. Almost 60% of women initiated breastfeeding for their newborns within 1 hour of birth. Overview of the Bangladesh health systems and services. There are 4 tiers of health facilities providing essential services to the citizens of Bangladesh. Community clinics are at the doorstep. They are over 13,000 in numbers, and each community clinic covers 6,000 population on an average. Community healthcare providers provide first aid, antenatal care, postnatal care, family planning services, and referral services. Second tier is the union facility, covering 24 to 30,000 population. It provides 24/7 MNH care, stabilization, and referral for complications and essential newborn care. Third tier is Upazila Health Complex, covering 250,000 population. They also have 24/7 MNH care, midwifery-led care model, and comprehensive newborn care. Lastly, district hospitals covering 2.5 million population and providing comprehensive obstetric and newborn care, special care newborn unit, and kangaroo mother care. Now, Mamuni MNCSP's collaboration with the Ministry of Health and Family Welfare. Mamuni Maternal and Newborn Care Strengthening Project is a USAID-funded 5-year project ending in 2023. The project is implemented by Save the Children and consortium partners and is working under the leadership of the Ministry of Health and Family Welfare and contributing to the Health and Population Sector Program. The project's aim is to increase equitable utilization of maternal and newborn care services. This ultimate goal is achieved through 4 interlinked intermediate results that are improved responsiveness of the system, improved quality of care, improved demand and household level health practices, and improved national capacity to deliver quality maternal and newborn care services. Key focus areas for the project activities. Mamuni tests and scale up evidence-based interventions like magnesium sulfate used for treatment of preeclampsia, active management of 3rd stage of labor, etc. The project scales up comprehensive newborn care package, essential newborn care, helping babies breathe, kangaroo mother care, special newborn care unit at the different health facilities. To improve quality of care, we are using proven model for improvement. We are also using maternal newborn health care improvement bundles, which I will explain later, designed by our consortium member, Institute for Healthcare Improvement. The project ensures that the basic emergency obstetric care services are available from more facilities. Removing inequity in terms of geography or financial remains a project priority. We identify hard-to-reach areas by mapping, consultation, and then introduce alternative service delivery model, engaging local government. The project has ensured services in a significant number of hard-to-reach areas, including remote islands and ethnic population sites. There are 2 breakthrough initiatives in digital data management system. One is electronic management information system. It digitized entire work of community workers and union level facility service providers. The other one is open medical record system, which is quite similar to electronic health record. And it automated system that enables using shared health records, and data is synchronized with cloud database. I will give you an idea of the project activities along with the continuum of care. Lipika Marma and her husband live in a village. When Lipika is newly married, then community health workers visits her at the household level with registration and behavior change communication activities. After getting pregnant, Lipika Marma visits a union facility closest to her house for antenatal care services. If she develops pregnancy complication, she is referred to a higher level facility. She delivers her baby there, but if her newborn develops complication, the newborn is referred to the district hospital to be treated at the special care newborn unit. The project also works with the teaching facilities named district medical college hospitals. If Lipika's daughter needs more specialized services, then she can go there. In this continuum of care, the project ensures facility readiness, develop capacity of service providers, improve quality of services, strengthen information system, and strengthen social accountability system. As identified in the health sector strategy, quality improvement remains as a project priority. A bundle is a structured way of improving the process of care and patient outcomes. It standardizes practice, supports service providers to set an improvement goal, implement change, and carefully record the improvement. There are sets of clinical bundles and operational bundles that are in implementation following the continuum of care. Currently, bundles are being implemented in 173 facilities and will be expanded to 226 facilities by the end of this year. The project collaborates with the Ministry of Health and Family Welfare and other stakeholders at the national level to scale up evidence-based interventions, developing standards of services, and other building blocks of health system strengthening. Here are a few examples of what the project accomplished at the national level. Mamoni MNCSP supported the ministry for the development of standard operating procedure for newborn health and also maternal health toolkit. The project supported National Newborn Health Program to develop a national newborn health dashboard that is used in national and divisional performance review workshop. Strengthening information system, electronic management information system has been expanded and open medical record system has been introduced. Scale up of proven interventions like active management of third stage of labor, use of magnesium sulfate and partograph, kangaroo mother care, special care newborn unit, etc. And improving quality of care remains as a core component for this project. In addition to implementation of maternal and newborn health quality improvement bundles, the project launched maternal and newborn health certification for both public and private facilities. The project is also supporting the ministry in developing national quality strategy and patient safety guideline. We are also advocating for establishing an accreditation system. Key achievements. Antenatal care is a gateway for pregnant women to come to a healthcare setting. In the project-supported facilities, 52% of estimated pregnant women received at least one antenatal care, which is 4% increase from the last year. Skilled attendant at delivery has a pivotal role in maternal and newborn health and survival. 19% of women delivered at public facilities that were strengthened by the project. Active management of third stage of labor is an evidence-based intervention for preventing postpartum hemorrhage, which is a major cause of maternal mortality. 37% of women received active management of third stage of labor in these 17 districts. Use of 7.1% chlorhexidine on the umbilical stump prevents newborn infection. 97% of newborns received 7.1% chlorhexidine after birth. The main causes of newborn deaths are preterm birth, intrapartum complications, and severe infection. Access to high-quality neonatal care can prevent most of these deaths. USAID's Mamoni MNCSP supports 19 special care newborn units where over 57,000 sick newborns were treated. Lastly, kangaroo mother care is a simple method of care for low birth weight babies. Around 4,000 low birth weight babies received kangaroo mother care services from 49 kangaroo mother care units that Mamoni MNCSP made functional. And Save the Children is implementing this project that I explained to you under the leadership of the Ministry of Health and Family Welfare, with 7 consortium partners and 5 implementing partners. You can see those names on the screen. Thank you.
Thank you, Dr. Meena. Now I would like to welcome Dr. Afshana Karim. Dr. Afshana has more than 20 years extensive experience in the development and implementation of public health programs. She has advanced level technical expertise in reproductive, maternal, newborn, child health, and nutrition services, and community-based health service approaches. Before joining Save the Children, she worked with the World Health Organization and International Organization for Migration. Dr. Afshana? Thank you.
Can you hear me?
Yes, we can.
Okay. So good morning and assalamu alaikum, colleagues.
Dr. Afshana, do you want to just do the full screen share or the slideshow mode?
Thank you. So good morning and assalamu alaikum, colleagues. I am Dr. Afsana Karim, the Senior Technical Advisor, Maternal Newborn Health of USAID's Mamuni Maternal Newborn Care Strengthening Project. In next few minutes, I will share the newborn interventions in Bangladesh, its outcomes, the challenges of implementation, and the way forward. In 2016, all the newborn interventions were integrated in 4th Health Population Nutrition Sector Program and the National Newborn Health Program established under the 4th Sector Program. The priority newborn interventions in the sector programs are the care for the all newborn, that includes essential newborn care and postnatal care for the newborn, care for small sick newborn includes the kangaroo mother care and antenatal corticosteroid, newborn resuscitation, treatment of the bacterial infection for the newborn, and care for the critically ill newborns at specialist care newborn unit. The intervention package also includes the promotion and prevention of newborn illness through social and behavioral change communication for birth preparedness, for newborn care, and care-seeking practices. This intervention package is named as the Comprehensive Newborn Care Package, and in coordination with the Ministry of Health and Family Welfare, implementation of this package was demonstrated by Saving Newborn Life project of Save the Children, and later on by USAID's Mamuni project. And USAID's Mamuni Maternal Newborn Care Strengthening Project supports the Ministry of Health and Family Welfare for scaling up of newborn interventions across the country. Since 2016, 7,500 healthcare providers were trained on essential newborn care package, comprehensive newborn care package. And before the CNCP, or the comprehensive newborn care package, during 2011 and 2014, the project supported training of more than 85,000 healthcare providers on 7.1% chlorhexidine. Around 35,000 healthcare providers are trained on helping babies breathe. As the IMCI protocol has been revised, the project supported training of 3,500 healthcare providers for management of infection in newborn. Moreover, 1,680 service providers are trained in kangaroo mother care. 675 service providers were trained on emergency triage assessment treatment, which is the key competency-based training to provide services in the specialized care newborn unit, and 231 were trained on standard operating procedure of special care newborn unit, that is the SCANO. The project also supported in development of the guidelines, materials, job aids for the availability of the drug and logistics, for capturing the newborn indicators in the service registers, as well as in the National Management Information System, and also facilitates systematic program review and data-driven decision-making. Currently, CNCP and the KMC scaled up in 64 districts. Total 54 SCANOs are functional, and the bed occupancy rate of the SCANO across the country is very high. In next few slides, we will look at the outcome of the key newborn intervention. What is the status of the essential newborn care in Bangladesh? The essential newborn care includes drying wrapping, application of 7.1% chlorhexidine onto the umbilical cord, skin-to-skin care, delayed birthing, and the early initiation of breastfeeding. According to DHIS, DHIS2 data, which captures only the services delivered at the facilities, all the components of ENC had an increasing trend. However, according to the Bangladesh Demographic and Health Survey 2017 and 18, which captures on the non-institutional deliveries, only 7.4% newborn received all component of ENC. And we have learned from the previous presentation that in Bangladesh, half of the women are delivered at home. So the country has an opportunity to work further to improve the essential newborn care in Bangladesh. A household survey was conducted in 10 districts of Mamuni MNCSP project in 2019. That analysis included more than 13,000 recently delivered women with a live birth outcome. The primary outcome was the mothers reported practice of skin-to-skin care. And this analysis shows 28% of the mothers reported skin-to-skin care practice. This practice was 42% in the public health facilities and 26% in the private facilities. The skin-to-skin practice among the mother who delivered by C-section was less than the mother who had normal delivery. However, a multivariate analysis shows the antenatal care visit from medically trained provider, facilitated delivery, normal vaginal delivery, mothers having complication during delivery were the associated factors with the skin-to-skin practice. With the scale up of helping babies breathe, there was a steady increase in number of babies with breathing difficulty who were resuscitated with bag and mask. This slide shows a decrease in the coverage in 2020 due to the COVID-19 pandemic, which has picked up in 2021, though the coverage is yet to reach the pre-COVID situation. Now, the kangaroo mother care. With the increase of number of kangaroo mother care units, what I have mentioned in my presentation, that around 250 kangaroo mother care facilities are established, currently functional in Bangladesh. The number of babies receiving KMC also increased over the year. However, the discharge from the KMC unit and the follow-up after discharge are yet to improve in compliance with the protocol. The pandemic has a similar impact in the scan utilization in 2020, though there is an increasing trend in utilization over the year. Mamuni assessed the service facilities for readiness, identify the opportunities to ensure the quality services as per standard, and also supports in establishing SCANU, procurement of this and installation of the equipment, ensuring availability of the medicine, etc. And the project supports establishment of 7 SCANUs and functioning of 19 SCANUs in country. Mamuni conducted an implementation research on strengthening small and sick newborn management, including the post-discharge follow-up. The study aims to improve the KMC and SCANU services and post-discharge follow-up. A mix of qualitative and quantitative data collection technique was used in 2 phases to monitor the trends. The quantitative data was extracted from DHIS2 and facility registers, and also from the KMC community follow-up forms and the phone follow-up record book. For the baseline, data was extracted from October 2018 to September 2019, and for the post-intervention from January 2020 to July 2021. This study was implemented in 1 district hospital for both SCANU and KMC, and in 1 sub-district level hospital for KMC only, as the SCANU services are available only at the district and the district level facilities. The key informants interview of the service providers and the managers, the focus group discussions with the community health workers, the group interview with the mother and the family members were also conducted. The strategies to improve kangaroo mother care readiness and the service delivery included the orientation and on-job training of the service providers, ensuring the dedicated trained nurse at the KMC corner, availability of the guidelines, commodities, job aids, and IC materials displayed in the strategic places, ensuring the privacy at the KMC corner and counseling, regular supportive supervision, and also the improved data recording and reporting system. The results showed an increase in the admission of the KMC newborn in both health facilities. In district hospital, 65% more newborns were admitted over the course of implementation, while the sub-district level hospitals, 4 times more newborns were admitted to the kangaroo mother care corner. The post-discharge follow-up was one of the challenging areas in KMC implementation. The identified strategies for KMC post-discharge follow-up were the strengthening of counseling, providers orientation, introducing KMC e-register with a pop-up option to highlight upcoming follow-up list, phone reminder by KMC nurses to the caregiver for facility follow-up, establishing KMC patient direct access to KMC corner, showing the KMC booklet during the follow-up visit, orientation of the community health worker, directory of the community health worker was made available in the nursing station, and a phone communication was established between the KMC nurse and the community health workers. The baseline data shows that that 47% newborn returned for first follow-up and 11% for the second follow-up and none for the third and fourth follow-up. And after the project intervention, all the follow-ups had increased. The key learning from this study was the adequate privacy of the kangaroo mother care corner inspires the mother and the caregiver to stay at the hospital or the facility for for providing the KMC care. The phone follow-up by nurses increased the post-discharge follow-up, and the caregiver and families feel encouraged for having the provision of direct access to the doctor, and the proactive and dedicated and trained pediatrician, nurses, and the community health workers are crucial to improve the services at the KMC corner and as well as the follow-up. Similar to the KMC services, projects supported ensuring trained nurse in Scano, developed admission and discharge criteria with technical support from Bangladesh Sheikh Mujib Medical University and the professional associations, ensured availability of the standard protocol job aid in the strategic place, and ensured timely equipment maintenance, developed Scano follow-up card, oriented the nurses at the Scano on phone follow-up, introduced phone reminder, introduced follow-up of counseling during discharge with follow-up card, introduced phone follow-up record book, and also established direct access to follow-up patient to the doctor without waiting in the long queue like the KMC. And the sick newborn admission at Scano increased from 15 to 24% at district hospital after the intervention. And 41% discharged baby received post-discharge follow-up at the facility, whereas it was almost zero at the baseline. Now, what are the challenges of newborn intervention? The priority new interventions are identified in Bangladesh. However, there is a poor readiness of the health facilities for newborn services, which is crucial for quality implementation of the newborn intervention. The strengthening implementation of the newborn services at all levels is required. Absence of dedicated and skilled health resources for the specialist newborn care unit is a challenge. The large network of the public sector health facilities is available in Bangladesh, yet there is a disproportionate overload at the secondary and the tertiary level facilities. And the care seeking increased, though there is a focus on the quality of the care is lacking. What could be the way forward? The technical and the logistics support needs to ensure for quality implementation of the newborn intervention. In Bangladesh, the death due to prematurity is around 19%. and establish and functionalize the kangaroo mother care unit in all the sub-district level facilities is crucial to reduce the death due to prematurity. Establish and functionalize the SCANUs in all district hospital is required, and demonstration of a model with private sector engagement for newborn care is the need for the current situation, and the provision of the separate inpatient facilities for treatment of the sick newborn who don't need the admission at the SCANU for reducing the high bed occupancy rate, especially at the tertiary level facilities. The countrywide reporting on maternal and the newborn data from both public and private facilities, we need to work on that. And the accreditation and the certification process need to be in place for both public and the private facilities. So with this note, I would like to end my presentation. Thank you everyone for patient hearing.
Thank you, Dr. Afshana. Now I would like to welcome Professor Shahidullah to give his remarks. Professor Shahidullah is professor and chairman in the Department of Neonatology at Bangabandhu Sheikh Mujib Medical University. He holds a number of positions, including immediate past president of Bangladesh Neonatal Forum, vice president of Bangladesh Perinatal Society, Secretary General of Child Health Foundation, Secretary General of Bangladesh Pediatric Association. He is a regular contributor to teaching and training manuals on essential newborn care available in Bangladesh and used by the government and NGOs. Professor Shahidullah, welcome to the virtual podium.
Yeah, thank you. Thank you very much, Sanchita Saxena, for very kind introduction. At the very outset, I like to thank the organizers for organizing this very important meeting. And at the same time, I like to take the opportunity to thank the two presenters, Dr. Mina and Dr. Afshana Kareem, for their brilliant presentation and stating what is going on in newborn health in Bangladesh, and also their particular contribution of Mamoni project, which is supported by USAID, and I like to thank other dignitaries. The two presenters, they actually have made a kind of a landscape presentation where they have highlighted the situation of newborn health, the programs that we have, the challenges that we are facing, and also they talked about the way forward as well. I will pick up about few important issues which Dr. Mina has raised, and also in my career, what I have observed in Bangladesh. When we talk about newborn health, we cannot ignore maternal health because it's a dyad and very closely linked with each other. And when you talk about the maternal health, the first thing that comes about the maternal mortality, its causes, what we are doing, and what should be the way forward. The maternal death has reduced significantly, but is still quite high compared to the expectation and what we see in the developed world. And many deaths are actually preventable. And those are not a very high-tech kind of interventions that are needed. We don't know the cause, which is common across this part of the world, that hemorrhage, preeclampsia, eclamptic toxemia, and infections. And these are all can be managed with a low cost but effective interventions. And by that, actually, we don't want to see the mothers are dying because of preventable causes. From there, when I talk about the newborn health, the neonatal mortality, which was quite high, and Mina has said that it has reduced, but the reduction is kind of, the decline is not very sharp compared to the decline that we see in the infant mortality rate and under 5 mortality rate. And when we know that 2/3 of this under 5 mortality is contributed by neonatal mortality, so naturally our focus should be newborn health and reduction of neonatal mortality. And we talk about that there are high-hanging fruits and low-hanging fruits. And using low-hanging fruits, which is low-cost effective, are very crucial and has proven to be quite effective. And whatever we have achieved now is because of that. Like Mina has mentioned about newborn care package, which includes a comprehensive newborn care. Then she talked about the improvement of the quality care. She talked about the facility readiness and the availability of capable human resources and the service, which should be 24 hours, 7 days a week. And all these have to be tracked by the management information system at scale. So that was what she said, but when I will be talking a little bit about Afsana Karim's presentation, and then I will come to a conclusion. Afsana Karim brilliantly presented about the program, the projects which are going on in newborn health in this country, and where the Malini project, particularly the USAID, made a tremendous contribution. And she said about key newborn interventions, and that includes mainly, I would say, essential newborn care. To my understanding, essential newborn care is very crucial, and it is doable, affordable. It can reduce huge number of deaths. And then facility ready delivery should be increased, which was nothing 30 years ago, 10% only, has gone up to 50 to 53%. Still, so half of births are taking place at home, so which is a kind of a big concern. And in Bangladesh, through comprehensive newborn care package, these that has addressed to the need of the newborn who are having problem in the community. And we really made some progress. But of course, the journey is long and it's not never ending one. When I say this, that we actually, I would say we were smart enough, and the government is quite pragmatic to think about the community newborn care more than facility newborn care, because that was affordable and that was more needed. When we are making some progress in the community newborn care, at some point of time, we realize, yes, there are still some babies who need special care. And that is in the facility. That is about prematurity and low birth weight, one of the leading cause. And some preemies need to be admitted. Then infection, then intrapartum complication when they have convulsion and other problems. They all need special care in a facility. And there comes the issue of scanning. As of now, Bangladesh, a country of limited resources, we have 54. And if I'm not wrong, 10 or 12 or more than that being supported by Malini. And you have seen in Afsana's presentation that the use of this scanner has gone up in a way that it cannot accommodate the number of babies who need to be admitted. So burden is more. And for a country like us, having a scanner in place, we face some problem like human resources. Sometimes we need to train them, and we train them, but retention of those human resources in the facility is sometimes not possible. Then again, your troubleshooting with the equipments. So these are all challenges that she mentioned, and she told about this. Finally, I will conclude here saying that if we need to make any improvement in maternal health and newborn health, it has to be a collaborative approach, where the government of Bangladesh should be in the driving seat, and as they're doing it, and it should be supported by the development partners and the professional bodies and academia. Because when you want to make real dent in terms of anything, the first of all that we need to have policy in place. And sometimes the policy is not being kicked off until unless there is some advocacy. And I like to, my hats off to Save the Children in USAID, one of the development partners, like others, have done a commendable job in policy development for maternal health and newborn health in Bangladesh. And once your policy is in place, then comes about the other things like programs and projects in place, costed analysis, challenges and bottlenecks to be identified, and then readiness of the facility. And finally, you capture the data, what you do through management information system, collate them, analyze, and act on that. So finally, my understanding is government of Bangladesh has made significant progress in improving maternal and newborn health, but need to do a lot. And here USAID Malini project program has contributed a lot. And I am a keen observer. And at the same time, I am a ally with the development partners to support the government. I will stop here. Thank you very much.
Thank you so much, Professor Shahidullah. Now I'd like to welcome Dr. Helen Pitchik. She's a postdoctoral researcher in epidemiology at UC Berkeley School of Public Health. Helen is also a former Chowdhury Center Research Fellow. Her research focuses on the design of effective, sustainable, and scalable interventions that invest in local capacity to improve maternal and child health and development in low resource settings. So welcome, Helen.
Thank you so much. And thank you so much for those great presentations from Mina and Afsana. They were really informative, and I was very impressed to see all of the work, the multifaceted, multi-component work that's been done across so many different health workers and delivery systems. Most recently, I've been working on delivering interventions through community clinics and family welfare centers. So a lot of the challenges and things that were learned in your intervention, I also experienced while working with many collaborators at ICTDRB. I have two main questions, and I'll keep this short because I know the audience also has a lot of interesting questions in the Q&A. Two main questions, one around delivery in public and private facilities. So I know you mainly delivered the intervention in public facilities and mentioned an accreditation process that you're going through with private facilities. I was wondering how, to learn a little bit more about how that works and how you managed working with both private and public facilities in your experience. And I also was wondering a little bit about the workload for the community clinic and family welfare center and Union Health and Family Welfare Center staff, and how you manage their workload with taking on a bunch of new interventions, and if you had to hire new staff, or kind of how you manage that with them. So that was short, but a couple questions to talk about in the discussion.
Thank you, Helen. So I'd like to welcome all the panelists onto the virtual stage, and so we can have sort of a roundtable discussion. So if you can just turn your cameras and audio on. And Dr. Shahidullah, will, are you able to turn your camera on as well?
Okay.
Wonderful. So I would like to actually open the floor now to Dr. Mina and Dr. Afsana. If you would like to respond, I don't know if you want to start with maybe responding to Helen's questions and then addressing Dr. Shahidullah's comments. So Dr. Mina, do you want to start?
Sure. So Helen was asking about deliveries of public and private facilities and our experience in working with them. So as I mentioned in my presentation that, so other than community clinics, we have some activities with community clinics, but those are not direct interventions. But in all other tiers, like Union Health and Family Welfare Center, MCWCs, Upazila Health Complexes, district hospitals, we are working. We are also working with number of private facilities in improving the delivery care. So our experience, of course, are different working in public and private facilities. For public facilities, the major challenges that we face are shortage of HR. And this is, I believe that this is not very Bangladesh specific. Any resource poor setting and also developing countries face the same problem globally. So that is one of the major problem. And our government introduced midwifery-led care in Upazila health complexes. So there must be 4 midwives in all Upazila health complexes. But unfortunately, we have either 2 or none. So this is the situation that we deal with. And so not only HR gap, but also facility readiness that I also mentioned in my presentation, and also in terms of comprehensive emergency obstetric care services, the maintenance of equipment, and also for newborn health care. If you talk about SCANU or other equipment where high-level equipment are required, the maintenance of those equipment are so inconsistent, and in many cases the maintenance system is just absent. So these are the major challenges that we face in ensuring quality of services from the public facilities. And our experience is working in private facilities. So the standardization of system, and we know that and in my presentation you saw that the more women, the women who are delivering in the facilities, more of them are going to private facilities because at least they have service providers. So in any type of complications, and when they are referred from a lower facility, they end up being admitted in the private facilities. So in fact, it was not that difficult for us to approach private facilities in inviting them in improving quality of services. They were open, but the challenge that we faced, they're not, when you invite in an open discussion, then sometimes they're not very comfortable in sharing their experiences with all other stakeholders, because the accountability system that we have right at this moment for the private facilities is something that needs to be improved to make them feel comfortable. So what we are doing, we are not going with certification process directly. We are establishing our relationship to improve their quality of services. I will give you an example. In one of the private facilities, when we started working, they did not have any labor room because they had like outpatient department of antenatal care and operation theater, you understand. So we facilitated the process, and in fact, they are one of the best facilities right at this moment in that particular district. So they were convinced now they have a specific labor room, and their service providers are maintaining partograph to take decisions. So we are working with them in improving the quality first, then we are inviting them to participate in certification program. I will stop here for the first question that you asked. And in terms of workload, Afsana, do you want to answer that question? Afsana? You are on mute, Afsana.
Sorry. So I can see one of the question on the on the
Helen's
ENC
question of workload.
Helen's question on the workload. Okay.
Workload.
Okay. Okay. So there is there are so many vacancies in the government structure. So many of the vacancies are still not fulfilled. So the requirement of the though there are many nurses are deployed recently, and also the midwives are deployed, but still there are scarcity of the human resource everywhere, especially for the BMOC, CMOC services, and also for the delivery care and the newborn care. Especially when we are talking about the union level facilities. So in that, the provider are the family welfare visitors. So there is also scarcity in the union level facilities for providing the delivery care as well as the essential newborn care. And we have also mentioned that the half of the deliveries are happening in the community. And though we have the community birth attendant program, but the utilization of that cadre is also challenging. So, for the scan, we have mentioned that there is a high utilization of the scan, and their bed occupancy is very high, but the dedicated provider in the scan and also the number of the providers in the scan is not enough to provide the services for each of the newborn. So I think, yeah, I think it answers the question. Is that okay, or do you want to? Is that satisfy Helen's question?
That's really helpful. So through the program, you didn't hire new staff. You were trying to go through existing staff, and there were some vacancies, so you had to adapt as appropriate.
There are vacancies,
yeah.
And also sometimes it happens that the skilled providers, they are shifted from one places to another place.
Yeah,
that also causes the hampered the service delivery at the facility, at the service delivery point.
I want to respond to Helen's question. I want to add with Afsana, Helen. So of course, our donor USAID wants us to implement a sustainable development program. For that reason, they do not encourage us in hiring additional people to provide services from the public facilities. However, there are very, very few staff that we hired in this phase. And what we do, however, of course, there are vacancies as we are discussing for last few minutes. So what we do, we engage local government at the union level. And it is their constituency. So they care about the health services availability for their constituency citizens, right? For that reason, we do a lot of advocacy, especially at the union level. We have activated the union level health and education committee, and their allocated fund. With our advocacy, successful advocacy, we make sure that the sanctioned fund is utilized for health activity. And with utilization of those funds, we actually were able to hire staff at Union Health and Family Welfare Centers, number of Union Health and Family Welfare Centers. And also those funds were also utilized for arranging drinking water for the facilities or paving the road for the facility, etc. So we are rather inviting local government representatives to take the charge of the facility, because they are the facility management committee members.
Got it. That's great to hear. Thank you.
Thank you for your responses. And then do either of you want to respond to Dr. Shahidullah's comments?
Sir, what was your specific comment that you wanted us to respond?
Oh, no, I made a kind of a overall comment. I mean,
right.
What's going on in Bangladesh, what the government of Bangladesh is trying to do, and what are the hiccups that mean the challenges that we face, the role of development partners, particularly USAID and Save the Children. Our role, overall, I said that my point is that we have to go a long way. The maternal mortality rate reduction, although we are saying that is good enough, but we need to make progress. Otherwise, we may see a kind of bad, what I would say, that the bad ending when we'll be reaching the SDG goal. Same goes with the newborn, because it's now stagnant. There has been a good, remarkable progress in reducing the newborn death in this country. But for last 7-8 years, I would say it's being stagnant. And we have to think in two ways, that we have perhaps utilized low-hanging fruits, where we can actually use the high-hanging fruit, that we have to be utilizing them. We have to utilize them. And the second point would be that we need to think and work sometimes out of box. Otherwise, we can't make progress in reducing the newborn death in this country. So that was kind of my overall observation and my comment.
So Mina or Afsana, do you want to respond? Otherwise, we can just go to the Q&A from the audience.
In fact, Sanchita, we have a lot of successes in newborn health. Yet, I know this is challenging, and we all agree that the newborn health improvement is challenging. But we have experience in really good partnership, as Professor Shahidullah was mentioning. As for example, I would say that in 2012 there was acting on the call, so to reduce the ending. So the initiative was called Ending Preventable Maternal and Child Death, and USAID took the lead, and USAID with other DPs and other international NGOs under the leadership of Ministry of Health and Family Welfare, 17 high impact interventions were identified, and they were scaled up. And I will give you one example of 7.1% chlorhexidine, where we had partnership with private sector, meaning that manufacturer, because at that time we did not have 7.1% chlorhexidine available in our country. So it's not only clinicians and professional bodies and DPs and ministry, but it was a wide range of stakeholder collaboration that happened successfully. And for that reason, we see that 100% of births that are taking place at the facility level are using 7.1% chlorhexidine. So of course, we have a long way to go, but there are evidences of successful partnerships and involvement of academia, professional bodies, and of course, clinicians and development partners. And in Bangladesh, the role of development partners are necessary, and they are playing a wonderful role in mobilizing Bangladesh government and supporting projects, and also providing support directly to the Ministry of Health and Family Welfare to scale up evidence-based interventions countrywide.
Thank you, Mina. So I think we'll go to some questions from the audience. There's quite a few. So the first one I'll read out. This is for you, Mina. Thank you for such a wonderful presentation. Is there any plan for the adoption of telehealth solutions at the community clinic level, which may help to reduce pregnant women to get some essential services and routine checkups during pregnancy without traveling to a UHC or district level hospital during emergency pandemics?
Thank you for the question. I saw that question in the chat box, and I wanted to actually respond to that question. And we do not have a lot of experience under this phase of the project, but the predecessor phases has had a lot of experience. Right now, so I did not mention it in my presentation because it's one district where we are testing a model where we are using mobile phone technology to send reminder to the pregnant women for their repeat visit for antenatal care and also for other visits. When they are supposed to come back to the facility, we are sending them reminders. In the predecessor phase of this project, we tried it both for pregnant women, women who recently delivered, and mothers of newborns, and also for youth. But for this project, we are specifically trying to see that sending these reminder messages to those women, what are the results that we can get from those reminder messages? If there, and we will be able to, shortly, we will be able to share those experiences, because we are now collecting data and carefully looking at the outcomes that we are getting from that. But definitely it's a great idea, and I cannot tell you exactly the percentage, but a big percentage of Bangladeshi population actually own a mobile phone, and a big percentage of them are also smartphones. So these phones can be utilized for a lot of purposes to improve care-seeking behavior and improve follow-up system. As you see that for antenatal care 1 services, women come, but for other antenatal care services, they do not come, like the subsequent visits. So using telephone technology, we are trying to invite them and remind them for follow-up visits. But this is, of course, this can be a very good intervention.
Thank you. So this is a question for Afshana. So two questions and comments. First is, pervasive health inequity exists relating to antenatal and postnatal care. In many village clinics, there are no doctors and adequate facilities. And the second point is, as far as I know, the prevalence of C-section has been increasing, often not for valid reasons. So the audience member's question is, do your projects have programs to enhance the capacity of community clinics in rural areas and slums in urban areas? This was directed to Afshana.
Okay. Thank you. So yes, there is inequity exists in the village clinic, and we have already mentioned that many of the lower level facilities, the people come to take the services, but sometimes the skilled providers are not available, especially. And in the community clinic level, the project we are working for all the level of facilities, and the community clinic, mainly we use this platform for engaging the community people, for supporting to the maternal newborn care services, the registration of the mother and dissemination of the information to the community, and also use the community power, the community people's resources for utilizing in the maternal and newborn care services. And in the urban areas, in the big municipality cities or the city corporations in the urban areas, the Mamuni is currently not working in those city corporation, but the as the Minister of Health and Family Welfare, you know, in Bangladesh, the Minister of Health and Family Welfare is not directly providing or implementing the services in the urban city corporations. It's mostly from the local government. So we are currently not working in the urban areas, but definitely this is the area where we need to work, and we need to work on the urban health. And another question was regarding the prevalence of C-section. Yes, the prevalence of C-section is high in Bangladesh. It's around 31 to 33% currently, and which is way above the recommended WHO rate of C-section, which is 10 to 15%. Thank you.
Thank you, Afshana. So there's an interesting question that I will open it up to all four of you, anyone who wants to answer. So the audience member writes, maternal health and newborn health, their survival are inseparable. Sadly, many programs separated both types of care. Being the director of whose Making Pregnancy Safer department, I have seen how Gates-supported Saving Newborn Care completely separated the newborn care from maternal health. More than 50% of newborn deaths happen during childbirth and soon after. The mother is the prime caregiver and provider of the newborn. So we must not separate these two. So that's, I thought, an interesting point. And any of you, all four of you, anyone who wants to respond to that, please do.
In Bangladesh, actually, the maternal and the newborn program both are under the same director, that is the maternal, newborn, and adolescent care. So that is the one of the operation plan through which the maternal and newborn care both are delivered in both the programs are looked after by in Bangladesh. Though there is separate program, but it is under the same director, and there is always the integration of the both the services in the service delivery level as well as at the policy and the program level. So we always try to do that integration and collaboration between the two, maternal and the newborn, both program. And it's in the same director.
And also, yes, sir. Yes,
no.
Go ahead, sir.
You go ahead first, and then I will try to supplement.
No, sir, I just wanted to mention that the professional bodies that lead us in these activities. So there are, of course, BNF, we have Bangladesh Newborn Professional Association, Forum Association, but we also have Perinatal Society. So the idea is to combine obstetricians and newborn health specialists. So this is also another initiative that Bangladesh professional associations do. Sir, over to you.
Thank you, Afsana and Meena, that you responded well. I just want to make a little supplement. The question that was raised by Dr. Munirul Islam was very, very important. That, I mean, that was the reality in the past. That maternal health was a kind of a standalone program. Newborn health was kind of a standalone program. They didn't have that much of linkage in the past. And when this was not only evident, this issue was raised, and I would say it's about 15 years back. And then the process began that how we can merge the two services. And rightly being said by Afsana Kareem, that the line director is MNCH. Under him is the both maternal service and newborn service. We have maternal health strategy. We have newborn health strategy. In both the strategy, they have one component of each other. Like maternal health, there is newborn component. In neonatal health strategy, there are maternal component. And the lastly, that of what I want to say, that all those very low cost effective intervention, what Afsana and Meena said, they are now in the curriculum of the midwives, nursing curricula, FWA and FWV. Those who are conducting the deliveries, they know the essential newborn care and also the other important newborn care. So there is a merging, but we need to deal a little more so that every program addresses both of them, and then we'll get a better result. Over.
And Helen, do you have any thoughts on this topic, you know, based on your research or even outside of Bangladesh that you could bring in?
Yeah, I'll share that the comment is familiar to me because in the work that I do, which is more early child development, a lot of the times interventions focus just on the child, but the mother's health and the mother's mental health are just as important, especially if she's the main caregiver for the child. So this issue of splitting the two is persistent and I think has been done a lot in the past, and also in the early child development field, everyone's working to kind of bring it together and have interventions that focus on both the mother and the child. Yeah.
Great. So I have there's another question, and again, any of you can answer this. This is around sort of behavioral change and campaigns that have taken place in Bangladesh. So the audience member asks, I know there are many behavior change communication campaigns in place in Bangladesh in the field of maternal and child health. However, was there any impact analysis conducted to understand the outcome of the campaign or these campaigns in order to understand how people can be encouraged to improve their health seeking behavior, we need to understand what is underlying their current behavior and what interventions can effectively influence them. The campaign should be more focused to be absorbed by the targeted groups and to ensure that all campaigns need to be very targeted to reach different types of communities and for people of different age groups. Has the project thought of adopting behavior change marketing approach, and what is a more targeted and proven method to improve health outcomes? So really around campaigning, any of your thoughts on that?
When it comes about USAID's Mamoni Maternal and Newborn Care Strengthening Project, we do not have a social behavioral change communication component as a part of our project, because USAID tries to wants their projects to coordinate with each other. And currently, USAID funds a project implemented by Johns Hopkins University and also other partners. They have other partners. That project is called Ujjibon. Save the Children is also part of that project. And through this project, they are conducting campaigns, especially on maternal and newborn health. So other health projects actually collaborates with Ujjibon, that project, to leverage their promotional campaigns in the community. I am not familiar with recent evaluation that took place. There might be one, but I'm sorry, I'm not aware of. But of course, I do agree, and I do agree with the comment that the components or the interventions need to be identified and implemented based on the evaluation findings. And we have one more year with our project, and I don't think that we will add SBCC component right at this moment. But of course, it will be interesting for us and useful for us to learn about such evaluation. The only behavior change not intervention, but component that we can address to our project activities is the interaction between service providers and service recipient, which we actually focus on. And we try to improve the counseling skills of service providers so that they can effectively communicate the messages with the service recipient. But I leave it to other panel members if they know about any evaluation from Bangladesh SBCC campaigns or projects.
Anyone else have any thoughts on that?
Rightly being said, I mean, the first of all, I like to thank the person who actually raised this issue about social behavior change communication. We know the strength of this. It can really mobilize population to the right direction. There has been a lot of campaigns, but the question that he raised, that whether any evaluation was done and what is the result, like Mina, I'm sorry that I do not know about it. But one comment in his last part of his message, which is which drew my attention, is that whatever the communication, behavior change communication strategy that we take, it has to be directed to the target population, and the target population is not similar or it's not uniform. So this behavior change communication has to be different for different target population. And I'm sure that the evaluation is very important, that whether how effective is this, whether we need to change any communication strategy or not. If anyone knows about the evaluation, I'd be benefited.
Helen, I don't know if in your work you've come across this or you have any comparative sort of research to draw on, like sort of campaigns that are sort of targeting behavioral change and how effective they've been. I don't know if you have any thoughts on this that you'd like to share.
Yeah, I think it depends on the behavior that is trying to be changed and what the block is to participating in the behavior. So is it awareness that that is a behavior that should be done, or is it resources? If it's resources, then it's hard to change the behavior through just information, because folks may need something other than information to get there. So I think it depends. There's definitely been successful behavior change campaigns in the world of early child development. Often behavior change in addition to coaching, like information in addition to coaching, is one way to encourage caregivers to change their behaviors. Sometimes information on its own is not as valuable as the pair of the two of them. So yeah, it's definitely possible, but it depends on the specific behavior.
Mm-hmm. So we're almost out of time. So I wanted to just again open it up to all four of you. Are there any sort of final thoughts or final remarks that anyone would like to make? I think most of the kind of key questions have been answered, or they were addressed earlier in the presentation.
Sanchita, there was a question that I wanted to address actually. So there was a question about strategies to reduce inequity. And as the project's aim is to reduce inequity, so I wanted to respond to that question. Yes, in fact, so we are working in reducing inequity in terms of both geographical inequity and also financial, because we are working mostly with public facilities. So in that case, we know that rural people and people who have difficulty to pay, they come to public facilities. So in that case, we are working in reducing financial inequity. And also our focus, we know that 28 million people in Bangladesh resides in hard to reach areas. So what we are doing a map in those 70 districts where we work. We do detailed mapping, we conduct consultation, we identify hard to reach areas, and we introduce an alternative service delivery model. And they will not match from one place to another, because there might be a remote island. In another example that I will give, that some tea garden workers. So the models are different, but through different models, and especially by engaging local government, we try to introduce essential maternal and newborn healthcare services for them. So of course, we are focusing on reducing inequity. And he also asked a question that why we are not working in North Bengal. So when we identified our project districts, we looked at several survey data, survey statistics, and also we looked at where other development partners are implementing similar type of projects. For that reason, we did not identify North Bengal as one of our project districts. So thank you.
Thank you, Meena. Afshana, do you have any final comments or thoughts that you'd like to share?
Thank you very much. So yes, for the newborn interventions, we are working for long in collaboration with the government, with the professional associations, and with other stakeholders, even agencies. So we will continue to work on that. And so the quality of the service is one of the key area where we need to work for reduction of the newborn health, and that is prioritized by the government. And all together we are working for that. So hopefully we will be able to reach the target for newborn death reduction. Thank you.
Thank you, Afshana. So Dr. Shahidullah, just a final comment?
My final comment would be that country like Bangladesh, we have a lot of things to do in the health sector, but it is always difficult for a country like us to prioritize and then focus because all are important, but you don't have the capacity to do that. So therefore, the role of the development partners and professional bodies are crucial. And I always emphasize on that. And I always want to say one thing, that the development partners, not only in Bangladesh, in any part of the world, if they have some kind of program or project or interventions, which finally end up kind of 5 or 6 years program, dissemination, but not taking it into the mainstream is not good. But in Bangladesh, there are plenty of examples where our development partners came forward to help the government, either with a kind of a program or project, eventually is mainstream. One is like this essential newborn care, kangaroo mother care, chlorhexidine use, scan-use. These are now in the mainstream, and now we need to actually push the government to take it up in a way that they have adequate trained human resources, logistics, and its management in place.
Thank you so much. And it looks like we're out of time. So I want to thank you again for these wonderful presentations, and to our discussants for your thoughtful engagement. Thank you to the audience for your engagement and your questions. And thank you again. Take care.